Hey guys, can you hear me? Hello, good evening. Good evening, Daksh. Am I audible? Am I visible? If so, say me yes. How was your Sunday? How was your week? Everything going good? I'm sure that your exam dates are nearing, and I'm sure that your preparation also must have been amped up accordingly, right? Okay. Good evening, then. Fine. So let's go with WBC disorders. So WBC disorders, it's similar to RBC disorders. It's very simple to revise because we have gone with a very superb template of B cell journey. We have gone with very basic things of the pointers, what is required with respect to WBC disorders. Right. The same way, this template. I am not going to change the etiology, mutation, and pathogenesis. Some of them might have mutation, some of them might not have mutation. Good evening, Samantha. Then diagnosis starts with history. See, this will be a common symptom, common history for any lymphoma, any leukemia, right? Good evening, Nikita. So whenever there's any lymphoma, by default, one of the classical symptoms is generalized lymphadenopathy, which could be definitely which will not be tender, non-tender generalized lymphadenopathy involving more than one of the lymph nodes. That's a classical finding. Or if it's not generalized, could be just a localized lymphadenopathy also, fine. Leukemia mostly will present with non-specific symptoms. I am sure that you must have solved previous year question papers from a university exam, right? Can anyone tell me what could be the symptom of leukemia? Most of the time, leukemia will have symptoms like fever, very non-specific. It could be because of the WBC being less, infection risk is more, fatigue, that's all. Purpuric spots, bleeding spots, right? All of the most of the time, leukemia specific will be very non-specific, except for few classical leukemias where I have specific finding. Rest every leukemia is mostly non-specific only, right? Like fatigue, malaise, right? It can be any non-specific finding. So for me to diagnose something as leukemia, since the history is very non-specific, there'll be more reliance on the peripheral smear or the microscope, right? That's where you diagnose a leukemia. History is very non-specific for leukemia and for lymphoma also. You cannot call it an Hodgkin's or non-Hodgkin's with history. Though there are few findings, but mostly it's very difficult to identify Hodgkin's or non-Hodgkin's via history, right? Then peripheral smear is required. Lymph node is required. If it's a lymphoma, lymph node is more important than a peripheral smear. If it's leukemia, obviously lymph node is not important. Peripheral smear is more important, right? And you go with markers. And last but not the least, prognosis or complication, if any, fine. So this will be the template. Again, headings are very important when you write an essay question or a short note answer, whatever it is, fine. So stick to these headings. At least you will be able to form a structure to question. Even if you know 1 point at the every heading, that makes solid 5-10 points. That's more than enough for any 5 mark or a long answer as well, fine. So that note, let's go on to leukemias. Okay, so first we'll go to ALL. See, this etiology table, I want you to do the same table for ALL as well as AML, Good evening, Lokesh. Because leukemias don't have a very specific etiology. It's very random. One thing I'm sure we must have read is benzene, alkylating agent, which is chemotherapy, drugs. I'm sure you must have read in your pharmacology, topotecan, irinotecan, etoposide. They cause secondary leukemia, right? Radiation by default can be a risk for almost every cancer and also leukemia as well. Good evening, Lion. Fine. Then hereditary. Few of the syndromes increase the risk of leukemia, fine. Good evening, Daksh. Okay, so one of the most important thing is Fanconi anemia, where you have a mutation in the FAN complex, which is a DNA repair complex. So it's not there. I'll have more mutation, which can result in aplastic anemia as well as leukemia. Ataxia telangiectasia mutation. It's actually an immunodeficiency disorder where I'm having increased risk of leukemia and lymphoma, right? Downs, definitely you must have known. Can anyone tell me what leukemia comes to your mind, especially when you think of Downs? It can cause both ALL as well as AML. When it's AML, I go for AML M7. ALL being more common than AML M7, but yes, it can cause both ALL as well as AML M7 by default. Fine. That's one of the Down syndrome can increase the risk of leukemia. Fine. Like I said, this etiology can be written for both ALL as well as AML. I'll add one more random syndrome for AML also, but there's a common etiology for both ALL and AML. When I take about acquired disorders, peroxisomal nocturnal hemoglobinuria, which is a stem cell mutation. If a stem cell is mutated, there's definitely a chance there can be a leukemia risk. Most likely AML, but there can be a leukemia risk, right? MDS, myelodysplastic syndrome, again, there could be a leukemia risk. Good evening, Piyush. Fine. This is mostly for AML, but it doesn't matter if you write it for ALL also, it's more than enough, right? So etiology is going to be same for both ALL and ALL. Ataxia telangiectasia mutated, that's ATM, fine. So we have sporadic, we have hereditary, we have acquired, just forming something. So you because first heading of any long answer, leukemia or lymphoma will be in long answer format only. describe the etiopathogenesis. I need to something to write. So I have 3 headings and randomly write a few things which will fit into that heading, right? So when I come to the pathogenesis of acute lymphoid leukemia, Rushikesh, without seeing the patient, cannot comment on that. 99 fever evening for 15 days, not good. Please consult a physician nearby, let them examine and then take a call on that. Fine. Okay, good evening, Puneet. Vanakkam. Fine. So let's go to pathogenesis. So pathogenesis, I'm going to talk about for ALL here alone. Whatever may be the etiology, it's ultimately going to cause mutation, right? So mutation for ALL, I want you to at least write these 2 mutations. These 2 mutations are must for me. One is PAX5 mutation. So PAX5 is very, very important for the differentiation of B cells, right? Okay. And also one causes notch mutation, notch3 if you want, otherwise at least write notch mutation. So in case of notch mutation, this will predispose or increase the risk of T cell ALL, and this will predispose and increase the risk of BALL. BALL undoubtedly is the most common subtype. BALL accounts for close to 85% of acute lymphoid leukemia. TALL is definitely rare, but it's little bit more aggressive, right? TLL is definitely more aggressive than a B subtype of an ALL, fine? So pathogenesis, just mention these 2 mutations. These 2 are must. PAX5 is a marker of B cell. It's very important for the development of B cell. So when you have mutation in that, development is altered, so it resulted in leukemia. That's all. Very simple pathogenesis, more than enough for both acute lymphoid as well as acute myeloid leukemia, fine? Let's come to clinical features. ALL, children or adults. The first clue for any ALL question is going to be the age. Please remember this, never ever forget this. There are only 2 things, right? Pretty dangerous, right? Official Saurabh Kumar, see, we'll discuss this sometime later. Let's go on with the questions. We'll definitely answer your questions, Saurabh. Please ping me later, fine? It's obviously seen in children, okay? So children, lymphadenopathy is a classical finding. If there is a question in the WBC neoplasms and it is seen in children, a child, right? There are 2 things which I never want you to forget. One is acute lymphoid leukemia, other is Burkitt's lymphoma. These are the only thing, at least for an undergraduate level, which will come for a children. Acute lymphoid leukemia or a Burkitt's lymphoma. I am 100% sure that you will know about Burkitt's lymphoma. Burkitt's lymphoma, jaw swelling. Acute lymphoid leukemia will not present with jaw swelling, right? So first clue is this. I'm not saying child alone will be equal to ALL. At least I'll think in terms of ALL. If I have a history of child, but the blast is MPO positive, what will be the diagnosis? Undoubtedly AML, right? So definitely child is a clue, doesn't mean it's ALL. It's a clue for ALL, clue for Burkitt's lymphoma. Undoubtedly the marker will decide me whether it's an acute lymphoid leukemia or an acute myeloid leukemia, fine? Okay, child with a generalized lymphadenopathy is most likely symptom, and I'll have features of bone marrow failure. So what do I mean by bone marrow failure? I'm having a tumor which is proliferating in the bone marrow, blast proliferating in the bone marrow. So I'll have very less space for RBCs. So I'll have reduced hemoglobin. The patient, like you guys said, can just present with fatigue. I'll have reduced normal WBC, that's bone marrow failure again. So there'll be infections or just a very non-specific fever, right? Just a non-specific fever could be the finding, right? I'll have reduced platelets. Once reduced platelets, can you have petechiae? Definitely. So you'll have petechiae, you'll have purpuras, you'll have bleeding gums, everything, fine? I am dangerous medical lecturer. I am from Tamil Nadu. I am from India, Chennai. Okay. Fine. Okay. So these are the features of a bone marrow failure. Fine. These are classical findings of bone marrow failure. Could be anything. Could be any of that. Most likely will be a non-specific fever or a fatigue. Could be the most likely history. But child having lymphadenopathy, all these features are diagnostic and characteristic. Fine. And let's go to CBC. Okay. So CBC. Definitely there will be in a long answer. The question will start with the CBC. So for me, the most important thing is an elevated TLC count. Total leukocyte count will be elevated. Definitely there will be an increase in the blasts also. Fine. Obviously in a CBC, I cannot say it's a lymphoblast or a myeloblast. I can say it's an increase in blast. That's all. Fine. So tell me, what is the percentage to call it an acute leukemia? If you have more than or equal to 20% in your peripheral smear or bone marrow or either of them. Peripheral smear or bone marrow, we call it an acute lymphoid leukemia. Or for any acute leukemia, I need to have more than or equal to 20% either in peripheral smear or bone marrow. Most of the time, peripheral smear should be more than enough for me. If it's not there, I go for bone marrow, fine. So once it comes to peripheral smear, how do I know it's a blast? Write this point by point when you are in exam, but here I will write it horizontally. For me to call anything a blast, the first criteria is it should be at least 2 to 3 times size of RBC. That's the first criteria. So you can easily draw a diagram, fine, saying that you put a normal RBC, draw a big cell 2 to 3 times, because there's no space for erythroblast to proliferate in the marrow samantha, so hemoglobin reduces, fine. Second, you'll have a high NC ratio. There'll be more nucleus, there'll be more cytoplasm, so more nucleus and less cytoplasm, there'll be a high NC ratio. Third, a very dark or a condensed nuclei. Condensed nuclei is very characteristic, or condensed chromatin is very characteristic of a lymphoblast, fine. Fourth, we'll have Saurabh, we'll definitely deal it later. I'll just go on with the class for now, fine. Fourth, you'll have no OR rods, no granules. So all these will tell me that I am dealing with a lymphoblast. I have no OR rods, no granules, we think of a lymphoblast, right? These are few classical findings to call me a blast. It's very simple to draw a diagram for a blast, right? Draw an RBC. For comparison, draw a bigger cell, no cytoplasmic granules, no OR rods, very high NC ratio, fine. So we have an old classification of L1, L2, L3 blast. Do write them, because most of your lecturers, at least for undergraduate level, will expect this, fine. L1 blast is very homogeneous. What do you mean by homogeneous? And they'll be a little bit smaller. They'll be more or less similar size. If I have 100 blasts, most of them more or less same size. L2 blast will be heterogeneous. So when you see heterogeneous population of blast, I'll have both smaller blast and a medium sized or a larger blast. So there'll be heterogeneous population of blast within L2. L3 blast is equivalent to Burkitt's blast. So Burkitt's blast has a very characteristic appearance. Burkitt's blast will have a high NC ratio as usual. Okay, the cytoplasmic color will be bluish in color, and in the cytoplasm you'll have vacuoles in the cytoplasm, right? Empty vacuoles, sky blue cytoplasm is characteristic of a Burkitt's blast, fine. Yes, Parag, it indicates myeloblast, fine. You'll have sky blue cytoplasm and you'll have clear vacuoles in the cytoplasm or empty vacuoles in the cytoplasm. Both will think of an Burkitt's blast or an L3 blast, fine. Okay, these are three different types of blast: L1, L2, L3. If you want to add prognosis, add it here. This has the best prognosis, this has the intermediate prognosis, and obviously L3 blast with respect to lymphoid leukemia has the worst prognosis. Though that's not the right way to determine, but yes, the prognosis based on the L1, L2 and L3, right? So we have a peripheral smear finding there. If you want write peripheral smear was also bone marrow, or if you say I want write separately for bone marrow, cellularity, will it be more cellular or less cellular? It will be filled with the same blast. Most of the time in bone marrow of an acute lymphoid leukemia, I'll have close to 80-90% of the entire bone marrow will be filled with blast, and it will undoubtedly be in hypercellular bone marrow, right? It's an hypercellular bone marrow because I'm having a leukemia. A leukemia cannot be less cellular. Hypercellular bone marrow filled with blast of the same thing, right? So that's more than enough for me to think in terms of an acute lymphoid leukemia. How do you confirm any leukemia? Anyone? What do you think is the investigation of choice? What do you think is the investigation of choice? Sure, Rahul, I'll do it. It's undoubtedly flow cytometry, right? So for every leukemia except for CML, it is flow cytometry. Daksh, pass is not an investigation of choice. It's a marker for sure, but it's a little bit less, right? So investigation of choice is definitely flow cytometry or CD markers. But like what Daksh said, markers, I have something called an immunocytochemistry, ICC. These are just stains. Okay, we'll just call it stains. Yes, lymphoblast will be pass positive. That's definitely right. A dot-like positivity for pass. PAS is definitely the one of these stains, but it's not very great, not very accurate. Definitely CD markers are much more accurate than a PAS stain, fine. So undoubtedly flow cytometry and CD markers are the way to diagnose any leukemias, also your acute lymphoid leukemias. Write for both BALL marker profile and TALL marker profile. One thing is common, both of them are coming from stem cells, so both of them will be positive for 34. Both of them are immature cells because they are blast. Immature lymphoid cells will be positive for TDT. Both of them will be positive for TDT, right? One B cell will be positive for CD19 and 20. What's the marker for T cell? Anyone? Simple, right? It's a CD3, right? So CD19 and 20 is positive for BALL and CD3 is positive for TALL. That gives me, okay, this is diagnostic of an ALL. By the help of CD markers are mostly done on flow cytometry only, fine, perfect, okay? So that covers the investigations as well, right? Always end with prognosis. I don't want you to talk much about the treatment of leukemias. If they have covered that in pharmacology, there are few regimens for treatment for acute lymphoid and acute myeloid. Write them or just give a word chemotherapy. Definitely an optional bone marrow transplant on a later stage. That's more than enough. But prognosis is something must which you have to be included, fine. So prognosis of acute lymphoid leukemia alone can come as a short note. It's based on age, gender, WBC count, involvement of different organs and structures, cytogenetics, and the treatment response. In addition to this, BTALL we have already discussed. T is definitely worse than B. And also we discussed about L1, L2, L3 blast. L3 blast is definitely worse compared to L1 and L2. You can add that here, but we have discussed in a different place. So let's leave that for now, right? Good prognosis, age 2 to 10 years. Good prognosis, less than 2 years, more than 10 years. Some books say 12 years. In simple terms, if it's in a child, good prognosis. Infant or very, very young or an older elderly person, definitely a bad prognosis, right? Okay. Gender, female, generally a good prognosis. And said white is generally a good prognosis, though it's a kind of a lopsided argument because whites have more access to healthcare, right? So men, male, and blacks, African American, especially with the US data, it has a little bit of a bad prognosis. WBC count, anything less than 1 lakh, or some books say 50,000. I'm going with 1 lakh because WHO says a lakh. Anything more than 1 lakh WBC count will have a bad prognosis marker. I can either call it WBC count or you can say the blast count. Okay, so the blast is more than 1 lakh or less than 1 lakh. WBC count more than 1 lakh or less than 1 lakh has a bad prognosis, fine. CNS testicular involvement, I want to add one more thing here, mediastinum. Which of these two leukemias will involve mediastinum? BALL or TALL? Definitely TALL, right? If it's not involved, it is a very good prognosis. If either of them, if it's either CNS or testis or mediastinum involved, it has a bad prognosis, fine. Moving cuts, we'll see it. I'll definitely cover it sometimes in the mid of next week, fine. Cytogenetics. So cytogenetics, I have very good prognostic marker. This cytogenetics, please do remember, I can use this same cytogenetic markers for different places as well, fine. So when you have anything, let's say that translocation 922, what's the finding seen in CML, but is present in AML, I think of a bad prognostic marker. Any translocations involving your 11q23, again a bad prognostic marker. And this also can be generalized everywhere you have an hyperdiploidy. It's kind of a good prognostic marker because in hyperdiploidy, it's a very 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 labile cell. It can easily die with chemotherapy, so it's a good prognostic marker. Undoubtedly, the final thing is going to be treatment response, right? At the end of 1 week after chemotherapy or after treatment, 21st day, there are no blast. It's one of the markers. At 21st day, post chemotherapy, if you still see blast in the bone marrow, then it's a bad prognostic marker, fine. Sort of, I repeatedly said you, we'll discuss that later. I'm just going to focus on the class, please. Okay, fine, we'll definitely talk about it. Please ping me on Insta. I'll definitely have a detailed chat on that, fine. Okay, so these are the differences between a good prognostic marker and a bad prognostic marker with respect to leukemias, fine. So we read about acute lymphoid leukemia. We'll use same template for acute myeloid leukemia, fine. Okay, so AML, so it's acute myeloid, not lymphoid, just correction, just make this correction alone. It's the same thing. I'm not changing anything. Same ionizing radiation, same drugs, same benzene, Fanconi anemia, your ATM Down syndrome. I've added only one more thing, Leigh-Fromney syndrome. Which mutation? Your TP53 mutation, right? P53 mutation, it definitely Leaf-Sprawling syndrome can predispose to leukemia, most likely an acute myeloid leukemia. Fine. Samantha, whenever a blast has an 1123 translocation, it gives a resistance to chemotherapy. So it's definitely a bad prognostic marker. Fine. Again, this makes more sense with case of an acute myeloid leukemia. PNH and MDS is more for acute myeloid leukemia, very rare for acute lymphoid leukemias. MDS is myeloid dysplastic syndrome, can progress to myeloid leukemia. That's simple, right? So here, I am not talking exactly about the pathogenesis efforts of an acute myeloid leukemia. I wanted to talk about the classification, because the classification of AML is actually the pathogenesis. All the mutations is required, right? So we have classified AML. This is based on the new WHO classification. If you want, write FAB classification sideways also, right? We have AML with recurrent cytogenetic abnormality 821, inversion 16, 15, 17. These three are very, very unique and specific, because these three are actually exceptions for what? We have read this. If you have either 821, inversion 16 or translocation 15, 17, it's an exception for perfect. The blast cutoff. It's exception for blast cutoff. 20% I don't require. Even if it's not 20%, please remember, if you have a history suggesting of an blast of less than 20%, but cytogenetics is positive for either of three, I'm still going to diagnose them as AML only, acute lymphoid leukemia only, right? And I have translocation with same 11q23 and normal cytogenetics and a mutation called an NPN1. This is the etiology, the mutation, the pathogenesis, and that's how the new WHO classifies. Or I have an AML with MDS or myelodysplastic like feature with a history of myelodysplastic syndrome, coexisting dysplasia, or a myelodysplastic syndrome associated cytogenetics. If you want, add one more word here. The myelodysplastic syndrome associated cytogenetics, monosomy 5q, is a classical myelodysplastic syndrome associated cytogenetics, fine, and AML therapy related. Same, your topotecan, irinotecan, all of them will be here, fine. Devangan, if I am going to prove it is, you are asking with respect to the blast percentage. In peripheral smear, if I can prove that I am having any of this translocation, bone marrow is not required. Okay, that's more than enough for me to call it an acute myeloid leukemia, fine. This is the new WHO. If you want to write the French, American, British classification, please go ahead, right? That's a bit easier. So we have AML from M0. M0 is totally undifferentiated leukemia. We have M1 and M2. M1 is without maturation. It's differentiation but no maturation. M2 is with maturation. With maturation means I'll have more than 10% of mature cells, the sites, everything, right? M3 is APML or acute promyelocytic leukemia. That's your translocation 15, 17. M4 is myelo, from myeloid, it's becoming monocytic, myelomonocytic. M5 is only monocytic. What is M6? M6 is erythroleukemia, erythroid. And M7 is megakaryocytic. Fine. Okay. Since myeloid cells gives rise to everything except for B cell and T cell, I can have myeloid leukemia involving all the WBC lineage except for B cell and T cell. B cell and T cells are your lymphoid leukemias. Undifferentiated, without maturation, APML, myelomonocytic, monocytic, erythroid, and megakaryocytic. Fine. So I have two different types of classification. WH is more commonly used. FAB might require in Viva, or if you feel like it's very less to write in the exam, please write FAB also, fine. Clinical features, like I said in the start, clinical features of an acute myeloid leukemia is very, very non-specific. Most of the time, it'll have features of bone marrow failure, mostly. Very non-specific fever, weight loss, fatigue, malaise, most of the time it will be there, right? But there are few very classical specific symptoms which I want you to remember for few conditions, right? Let's say I'm having a patient with an APML or an acute promyelocytic leukemia. Can anyone tell me what's a specific symptom? Yes, Samantha, WHO classification is the one which we follow. It's simple. Recurrent cytogenetics we already know as an exception. 3 of them is there. And just now you asked a question of translocation 1123. Add that and one more NPM1 and have your MDS and therapy related. Okay, perfect. DIC. They can present with DIC, right? That's a very classical symptom. APML can present with DIC, fine. Now, when I say AML M4 or M5, any classical symptom comes to your mind? Is one classical symptom. M4 and M5 has a little bit of monocytic component. Monocytic component can go to tissue. You can just write chloroma. chloroma is extramedullary blast. I can have blast outside the bone marrow, right? I can have an extramedullary blast. Perfect. One of the classical examples of chloroma is your gum hyperplasia. Please guys, please be very careful in an exam. Do not confuse gum bleeding with gum hyperplasia. Fine. Namaskar Pratik. Gum bleeding is different. Gum hyperplasia is different. Okay. Gum bleeding could be a symptom of, can it be a symptom of acute lymphoid leukemia? Platelets are reduced. Can gums bleed? It can. Gum bleeding is a very non-specific symptom. Don't confuse them with gum hyperplasia and write as AML-M4. Bleeding is can be due to thrombocytopenia, can be due to DIC also, right? It's a very non-specific symptom. Don't confuse that. Fine. Okay, it's gum hyperplasia, can be seen in AML-M4, M5. If it's AML-M7, again few classical findings. This will be seen in children. Okay, and the patient will have myelofibrosis. Whenever a patient has myelofibrosis, one of the classical symptoms is a massively enlarged spleen. Okay, so patient might present a very dull aching pain in the left side of the abdomen due to the massive enlargement of spleen. Child, massive spleen, think of AML-M7. Gum hyperplasia, not bleeding, think of hyperplasia or hypertrophy, whatever it is. Fine. Think of AML-M4 and APML, DIC could be the symptom. Right. These are few specific symptoms. Most of them will be non-specific only. Right. So we know the symptoms. Let's come to CBC. CBC same like acute lymphoid leukemia, elevated TLC. You'll have more than 20 or equal to 20% blast. The blast will be of myeloblast. We will soon see how to pick up a myeloblast. I'm sure you know how to pick up a myeloblast, right? So blast cutoff exception, if there is any of the three, if there's any of the below, you can call it an acute myeloid leukemia without the blast percentage. Inversion 16, translocation 18-19, sorry, 8-21, translocation 15-17, right? So any of this, you will call it as an blast exception. You can call it an acute myeloid leukemia directly, right? Now let's look at the features of in peripheral smear. First feature is definitely the number more than equal to 20%, either in PS on bone marrow. I just included one characteristic finding for every leukemia if it comes. Because in microscopy, I cannot identify the translocation. The only thing I can identify is a myeloblast or a monoblast or a megakaryoblast or an erythroblast. So that might help you in writing a little bit more about the microscopy. So ultimately it's blast. One common finding for every blast is size, right? It's definitely going to be increase in size, at least 2 to 3 times of an RBC. This you can write for every blast, be it a myelo, be it a mono, be it a megakaryo, be it an erythro. All of the blasts will be more size. All of the blasts will have a high NC ratio. Okay, this is true for every blast. These both, please write for every blast. Please repeat it. If it's a pure, just a neutrophilic or a myeloid lineage, I'm just going to call it only one thing. That's more important for me. I'll have either granules or rods. Or rods are also granules in the form of a rod. That's all. Hello, Nikhil. Fine. So either granules or rod, we can call it a myeloblast, right? That's a classical finding for a simple myeloblast. That's more than enough. Fine. They will have nucleoli. They'll have open chromatin. If you want to add more, add more. But this is at least bare minimum I want you to write. When you come to AML-M3, same thing. High NC ratio, increase in size will always be there, right? Two classical findings. So there'll be an excess amount of OR rod. What is the name called as? Because it looks like a bundle, we call it a faggot cell, right? Bundles of OR rods is classical for AML, M3 or APML, and then the nucleus. The nucleus will have a very deep cleave or an indentation. It's an extremely cleaved nuclei. So it looks like a buttock, right? A buttock shaped cell because of the cleaved nuclei, and the excess of OR rod is a classical finding for an APML, right? And you can draw an image of an OR rod, not very difficult. Draw a nucleus here, put multiple rod-like structures here. It makes a faggot cell, right? Faggot cell and a buttock-shaped cell for APML primarily. M4 is monocyte, right? M4 has again the two findings, high NC ratio and a very big cell, more than 2 to 3 times of nuclei is template, right? In addition to that, they have something called a lacy chromatin. It will be very kind of not thick, very thin or a lace-like chromatin. It's very open chromatin, so called lacy chromatin, and the nuclear shape. Nucleus like any normal monocyte, it will be kidney shaped, right? A kidney shaped nuclei and a lacy chromatin, no granules, I think of an AML M4 M5. But undoubtedly, I need markers. This is the first step, right? AML M6, they will have a completely blue cytoplasm because normal pro-erythroblast, what you read in normal WBC lineage, will have blue cytoplasm because of good amount of hemoglobin's RNA. That's why it's blue cytoplasm. Then it have a perfectly round nuclei. A perfectly round nuclei, a blue cytoplasm is diagnostic of an AML M6. AML M7, yes, NSE is positive for your M4 M5 Daksh, right? AML M7, you will have bleps in the cytoplasm. If you have bleps on the cytoplasmic membrane, which is nothing but the platelets which have been formed, I call it an AML M7. That's a very classical finding. Lacy means like a lace. Lace is a texture of like a socks. Socks will be netted, right? So it'll be very, very thin. It'll be like a see-through, kind of a very thin or open chromatin. So we call it a lace-like chromatin. Fine. Okay. So here, so bleps is that classical here, high NC ratio again, but tiny, tiny, tiny bleps on the surface of cytoplasm is diagnostic of an AML M7. Fine. Lace means okay, Jalidar. Okay, fine. I'll remember Aniket. Okay, perfect. So these are few clues for me to identify it's a acute leukemia of different types of AML, right? Just few words, two words, right words are more than enough for an exam under every heading. But it should be right. If you're writing story, write a page. If you're not writing story, very accurate, be accurate, fine. So investigation of choice here also is same flow cytometry, but I do have stains as well. So stains for any myeloid lineage, what's the best marker? For every myeloid lineage, my best marker is undoubtedly MPO, right? Like Daksh said, for M4 and M5, I will think of NSE, a non-specific esterase. Blebs is not swelling. You must have, if you have seen boil, tiny boils are called as blebs. It's projection from the surface, fine. MPO is the best, SPB also, Sudan Black B also, if you want, you can write, fine. Right, non-specific esterase is a classical finding for M4, M5, fine. AML M6, they are again PAS positive, but they are circumferential positive. It's positive throughout the cytoplasm. It's a circumferential PAS positive. Again, M7, it's also PAS positive, but it's granular positive. Okay. If I want the marker stains, I'll go for this. But as you know, this is not very specific. Specific is always your immunohistochemistry or your CD markers, which can be done with flow cytometry. Okay. For any AML, I'm not writing M1, M2, M3. They don't have a very specific thing. So for every AML, the first thing for me is CD34 because they are blast. Every blast will be positive for CD34. In addition to this, if it's myeloid, which includes from your M1, M2, M3, everything will be grouped under myeloid. The best marker for me still is myeloperoxidase, right? If it's monocytic or monoblastic, we have CD14, we have CD64. I'm not mentioning CD13 and 33 line for the only reason we'll go for one since the final thing, right? You can add to this your CD13 and CD33 also, but MPO undoubtedly is the most important thing. Apart from that, yes, 1333 also is required, fine. Okay, then AML M6, simple, hemoglobin. Okay, M7, can anyone tell me the markers for AML M7? If you're not sure about the markers for AML M7, it's very simple. Just write glycoprotein 2B3A. That's enough. Actually, the marker is actually nothing but the glycoprotein 2B3A. Just write glycoprotein 2B3A because glycoprotein 2B3A you will never forget. It's seen on the platelets. If it's seen on the platelets, it's seen on your megakaryoblast also. That's more than enough. Okay, that's your marker for your AML M7. That's more than enough. Very simple markers. One marker for everything, right? If you want to write little bit elaborate, right? AML M4, it will be positive for CD34. It will be positive for MPO because they do have myelomonocytic, and it will be positive for NSC. It will be positive for 1464 as well. Fine. Okay. Perfect. So that's a marker for your AMLs. So prognosis here, I'm not going with the prognosis for the only reason. Prognosis is actually based on the classification in AML, right? So if you look at this AML classification, all these three will have good prognosis. The first three, wherever I had the cutoff blast percentage, all of them have good prognosis. Whenever my translocation 11q23 comes, be it an acute lymphoid or an acute myeloid, it will have a poor prognosis. This will have an intermediate prognosis, to some extent good only. Fine. Anything with MDS like features, by default poor. Anything secondary therapy related, by default a poor prognosis. Fine. In FAB, we don't go generally with prognosis because the new classification is prognostic. This was based on the microscopy. I cannot exactly correlate to the prognosis. That's why we came to the new classification, right? So in the classification, you know the prognosis. If you want, add a little bit more there. Okay, if I see this finding, I think of good prognostic marker. Blast being more, blast being less. Again, those are all non-specific things which you can write by default, fine. So you know about acute myeloid leukemia, your etiology, classification, which is also prognostic, clinical features and few specific clinical features, CBC and type of blast, and obviously your markers and flow cytometry. That's more than enough, fine. Let's go to lymphomas. So for lymphomas, every lymphoma, the template is very simple. Write the origin of lymphomas because every lymphoma is classified based on the origin. Either it's an germinal center, pre-germinal center, post-germinal center, fine. Devan, and there's a question for everyone. Do you guys have history in case of practicals, especially with leukemia, or they'll just give the slide? See, when I was teaching in a college, that time we used to give history, and then for leukemia at least we will focus the OR rods and keep it, and we'll write them, don't change the field. That's how we used to tell them, because it's very difficult for an undergraduate to identify the blast in 2 seconds, right? Okay, if it's focused and kept, just look for only one finding, OR rod. If OR rod is there, it is myeloid leukemia. OR rod not there, lymphoid leukemia. Ideally it should be with history, but I don't know why your teachers are not very good to you. It will be with history mostly. If it's not with history, look for the OR rods. That's the classical finding here. Otherwise, the last but not the least, you know the number of leukemia slide right there again. Look outside the microscope. That's the last resort. But if there's history, go with history first. If it's a focus blast, go with the OR rods. If not, finally, obviously we have the slide number, fine. Because I don't expect an undergraduate to identify a leukemia in a microscope. Let's be honest, because it's difficult to identify. That too in exam stress, you'll not be able to identify, fine. If that is the only problem, please ignore them. Don't worry about it, fine. Okay, let's come to CLL SLL. So for every lymphoma, origin, mutation, pathogenesis, history. History I will not repeat. If there's a specific history, I'll add on to it. But every leukemia you'll have elderly with generalized lymphadenopathy. Lymphoma. Every lymphoma is seen in elderly except for your Burkitt's lymphoma, while the history is totally different, which you know that, fine. Okay. Good college land, but bad for you, right? If there's any specific history, I'll add on to it. Peripheral smear will not be there for most of the lymphoma. CLL is a leukemia and lymphoma, so it's there. And then lymph node. Then I'll talk about markers. Obviously, I'll talk about one CD marker. You can add on to it, but one marker, that alone, don't make a mistake. Others, if you add on to it, great. And prognosis and complication, if possible, let's write a word about that, fine. Okay, let's come to your CLL. Okay, the mutation or the primary problem in CLL is there's an overexpression of CD5. That's a problem here. CD5 overexpression increases a thing called as BTK, which is Bruton's tyrosine kinase. Okay, so when there's overexpression of Bruton's tyrosine kinase, it's a tyrosine kinase, right? So every tyrosine kinase undoubtedly will result in more amount of cell division of a naive B cell. This word is very important. When you talk about CLL, SLL, we talk about the pathogens of CLL only because that's the chunk. SLL is very, very less, right? So when I say naive B cell, which automatically tells me the origin is pre-germinal center origin. But if it's an SLL, it's a post-germinal center origin, different mutation. But like I said, it's not much required. CLL is the most common thing. We'll talk about CLL only. Overexpression of CD5. If you are finding it difficult to memorize CD markers, whatever is the etiology, that will be the most important marker for me. Remember that alone. That should be more than enough for us, fine? Okay. Now, let's come to your history. History is generalized lymphadenopathy. Elderly person, that's classical. one more important unique finding, CLL can present as hemolytic anemia. So anemia can be a symptom or history related to it because CLL can cause hemolytic anemia. We did read about hemolytic anemia yesterday. The warm as well as cold, CLL is one of the unique findings, right? Peripheral smear. It's a chronic leukemia. So we'll have blast or mature cells. Mature cells. So we'll have perfectly lymphocytes or lymphocytosis. I'll have more amount of lymphocytes plus one classical finding correlation, smart cell. Smart cell is diagnostic for a lymphoma. Smart cell is diagnostic for a CLL, right? If you want to draw the diagram, destroyed cell is smart cell and you have a classical mature lymphocyte. Mature appearing lymphocyte, smart cell, is more than enough to say it's a CLL. Lymph node. Again, I'm going to tell you one finding which is common for every lymphoma's lymph node. What is that? I won't repeat this again. It is every lymphoma, the first word will be effaced lymphoid architecture or the lymph nodes architecture. Lymph node architecture being effaced is the classical finding. So if you want to elaborate on this, effaced architecture means I won't see the cortex medulla, follicles, parafollicular area. That will be destroyed. It will be an effaced lymphoid architecture. This is common for every lymphoma. Like we said, this is common for every lymphoma. This also is common for every lymphoma. Fine. In addition to this, there's a finding in microscopy called proliferation centers. Proliferation centers will be present in case of a lymph node biopsy if it's SLL. Proliferation centers are nothing but the place where the tumor cells originate in a lymph node. We call them proliferation centers. Just a word is enough, fine. Then markers. CLL, SLL, Mantle, your Burkitt's, DLBCL. Can I say all of them are B cell neoplasms? Yes, no, maybe. They're definitely B cell neoplasms, right? Okay, they're definitely B cell neoplasms. So something is B cell neoplasm. Can I say by default there'll be 1920 positive? I'm giving you a few template which I never want you to forget. Perfect, right? So these markers, the tumor cells will be 19 positive, 20 positive. This I can again elaborate for every B cell lymphoma. Hodgkin is also B cell, I can write it, right? So every B cell lymphoma, I can write this, right? In addition to this, one thing which I never wanted to forget is CD5. Because CD5 was the guy which was involved in the pathogenesis. And if you want to add on to it, 23 positive. Okay. CD5 positive, 23 positive, 19 positive, 20 positive, more than enough for me for markers, right? But please don't forget this. Whatever is the pathogenesis, don't forget. Others are all extra. If you forget the pathogenic marker, I might be worried, but others, it's fine. For every lymphoma, I can write 1920. It's a T cell lymphoma, I can write 3. That's by default, fine. Prognosis. The prognostic factors, if you have CLL with anemia, with thrombocytopenia, and with a diffuse bone marrow involvement, all these are classically a poor prognostic factor. Okay. And one important thing, complication, just a word. Can CLL become DLBCL? CLL can progress to a high-grade lymphoma, which is DLBCL. DLBCL transformation, we call it Richter's transformation. Obviously, Richter's transformation is also a poor prognostic factor. Fine. You need not remember a lot like leukemias because CLL alone can never come as a long answer. Maximum a short answer, right? No one is going to ask you CLL or Mantle or Burkitt alone as a long answer. It will be a short answer. So few words about prognosis, 2 words are more than enough for the prognosis, fine. Same template we'll be using. Origin, along with the mutation, you'll have the pathogenesis also. History is a template. Lymph node architecture is a template. 2 things. I'll add extra findings, that's all. If there's any extra finding along with the template, we'll add it. Peripheral smear, only for CLL. Mantle, Follicular, and Burkitt's will not have peripheral smear finding. Then markers, whatever is the pathogenesis, write that marker, add on this non-specific things together. And one word about prognosis or complication, fine. Mantle. Can anyone tell me what's the translocation for Mantle? Mantle's translocation. Smart cell is a classical finding seen in CLL, which is a destroyed lymphocyte, which comes to the periphery. Mantle, remember MANLL, right? So TLL, right? Mantle is translocation between 11 and 14. So because of this, there's an overexpression of the chromosome 11's product, which is cyclin D1. Chromosome 11 is cyclin D1, which is overexpressed. When cyclin D1 is overexpressed, there's an increased G1 to S, because cyclin D1 involves in the cell cycle in the S phase of cell cycle. So when a cell moves very fast through a G1 to S phase, automatically I'll have definitely more cell division. That by default is going to result in a tumor. Fine. So since we know this about Mantle, we know the pathogenesis, we know the mutation as well, right? The name says the origin. Origin for Mantle is undoubtedly the Mantle zone of the lymph node. If I have to be very specific, pre-germinal center. Fine. If it is specific, pre-germinal center, otherwise it's a Mantle zone of lymph node. Whatever you write, that should be right. Fine. GC stands for germinal center. Fine. That's classical. History again, Mantle cell lymphoma can present as nodal and extranodal. Nodal is your same. I'm not going to repeat. Generalized lymphadenopathy, elderly by default, right? Elderly plus generalized lymphadenopathy. I write E plus GL for elderly generalized lymphadenopathy, plus Mantle is also called as an lymphomatoid polyposis. So Mantle is one more name is lymphomatoid polyposis because they can present with polyps in the intestine. So that's very, very classical. That's a classical finding seen for mantle cell lymphoma. None other lymphoma present as polyp, a unique finding. Fine. Again here, effaced architecture is classical for every lymphoma. Obviously the mantle cell lymphoma, right? So one more finding is an expanded mantle zone. Expanded mantle zone and an effaced architecture of the lymph node is diagnostic of a lymph node finding in case of mantle cell lymphoma. Go with templates. It's very easy to fill the template. Now next is marker. Is mantle cell lymphoma a tumor of B cells? Yes. So marker is easy. 1920 by default. The mutation was cyclin D1. That's the most important thing for me. Cyclin D1 is positive, right? Mantle is also positive for CD5. Because they are pre-germinal center, every pre-germinal center will be positive for 5. Again, if you ignore 5, does not matter for me. But don't forget cyclin D1. I expect an undergraduate minimum to write cyclin D1. 1920 you will definitely write it, right? Prognosis, mantle can also become DLBCL, or more problem with mantle is it can become something called a blastoid mantle cell lymphoma. It's a very aggressive variant. Here I can have peripheral smear involvement. It can come to the peripheral blood. When I say blast, it's always involving bone marrow and peripheral smear. That obviously is one of the complications of prognosis, which has a very poor prognosis. Fine. Okay, that's with mantle. Origin pathogenesis, history is more or less same. Lymph node, again one finding more or less same. Marker you already know. Little bit about prognosis. That's it. Fine. Follicular. Translocation follicular. Anyone? Translocation follicular. Perfect. Translocation 14-18. Because of this translocation, there's going to be an overexpression of chromosome 18. In chromosome 18, we have BCL2. Fine. We have BCL2 in case of chromosome 18. Overexpression of BCL2. Obviously, BCL2 is an anti-apoptotic gene. So, it will be an extremely long life of the cell because of BCL2. So, automatically, it will accumulate more mutations, which by default can result in a tumor. Can result in a lymphoma here. Fine. Mantle cell, follicular lymphoma origin, it's follicles. So it has to be a germinal center origin. If you want, write centrocyte. Centrocyte is the exact origin for follicular lymphoma. If you write germinal center also, it's more than enough. That should be more than enough for us. Fine. Most important thing, mantle cell lymphoma is one of the most slow growing or a very indolent lymphoma. It's a very indolent lymphoma. It grows very slowly. Fine. Why I mention this is that will give my clinical history. If it's a very slow growing lymphoma, very rarely they present generalized lymphadenopathy, right? So it's elderly, a single node or a single group, mostly for years. Since it's very slow growing, cervical lymphadenopathy for years, right? KMT2 mutation is one of the classical findings seen in follicular lymphoma. You can add on to that, right? But generalized lymphadenopathy in follicular is a bit unlikely. Fine. Lymph node, again the same finding, effaced lymphoid architecture. How it's effaced? it will be replaced by follicles. We'll have replaced by follicles in both cortex and medulla. In both cortex and medulla, we'll have lots and lots of follicles. It's replaced. Image like this. If you can just draw something and put multiple rounds, replace by follicles, that should be more than enough, right? So we know the history, we know the lymph node. Obviously, I'm going to diagnose investigative choices, markers or ILC, right? Follicular lymphoma is again B, right? So 1920. The mutation was BCL2. This is more than enough for me. There is a germinal center marker. If you want, add on to that CD10, BCL6. These are germinal center markers. I'll write GC markers here. If you want, add. Otherwise, remember what you want to draw. Draw a lymph node pictures. Just put a square, draw a lymph node, and say I'm having multiple follicles both in the cortex and medulla. Just if you want to represent it in draw this. It doesn't make sense, but if you want to make a push yourselves to draw a diagram saying these are multiple follicles in a lymph node. Fine. Okay. Prognosis. Follicular lymphoma is a very, very low grade lymphoma, right? But follicular lymphoma can also progress to DLBCL. That's one of the complications. If it progresses, I'll have a poor prognosis. Otherwise, follicular lymphoma has a very good prognosis. Because of the indolent thing, follicular lymphoma can also go to bone marrow. Bone marrow involvement is there. It's gone unnoticed. In most likely 2/3 of the people, they present with bone marrow involvement, and most of the time bone marrow involvement will be paratrabecular location or a paratrabecular involvement. The tumor cells will be in the paratrabecular location. That's classical for a follicular lymphoma. Don't forget this. Indolent lymphoma, patients don't come to the doctor, not diagnosed, goes to bone marrow. Any lymphoma involving bone marrow is grade 4. And it can progress to DLBCL, definitely a bad prognostic feature. Fine. Okay, that's about Mantle. Okay, let's go to Burkitt's. Burkitt's origin and what's the mutation? Burkitt's microscopy you definitely know, right? Burkitt's origin is simple. It's also going to originate from germinal center. To be specific, centroblast. It's Burkitt, right? It's translocation between 8-14. If you want to get a honors or distinction, 2-8, or I have translocation between 8-22. Ultimately, chromosome 8 is what is required for me, right? So chromosome 8 translocation is diagnostic of Burkitt. Star is K obviously there, right? So because of the chromosome 8, there will be overexpression of chromosome 8. So we have CMYC here. There will be increased CMYC, right? CMYC is the one which is going to increase the Warburg's effect because it controls the Warburg's effect. So if it increases the Warburg's effect, Warburg's is seen in normal cell or stem cells. They are seen in stem cells, right? So whenever there is more Warburg's effect, it gives stemness to a lymphocyte. So when it gives stemness to a lymphocyte, it behaves like a stem cell. There will be uncontrolled proliferation, which by default results in a tumor, results in a lymphoma. Fine. That's the simplest pathogenesis of your Burkitt's lymphoma. But CMYC or MYC, anything is fine, but that's very, very important for us. Fine. C is cytoplasmic expression. I have CMYC, I have NMYC. Just remember MYC, that's enough. Fine. Okay, now history. History is where I want you to divide them and write them as endemic Burkitt's lymphoma and sporadic Burkitt's lymphoma. But both of them will be predominantly seen in children, right? Endemic, obviously seen in African continent. It's very, very common and it's almost always due to EBV. And that's where you classically see them in the jaw, right? Okay, you see classically in the jaw. Jaw swelling, destroying the jaw, classical finding for a Burkitt's lymphoma. Sporadic, it can be nodal. When it's nodal, it will be a child presenting with lymphadenopathy, or it could be an intraintestinal lymph nodes as well. Burkitt's also can present in extranodal like Mantle in the intestine, but Burkitt's don't present with a polyp, they present with intussusception. Okay. Intussusception is a classical finding seen in case of Burkitt's lymphoma. Polyps is a classical finding seen in case of a mantle cell lymphoma, right? This classification Sporadic, endemic. Endemic is mostly in jaw. Sporadic can be nodal or extranodal. Extranodal, it can present in GIT. If it's presenting in GIT intestine, it can present as interception. Fine, that should be enough. Interception is a telescoping of intestine. You'll read more about that when you come to your surgery. It's an intestinal problem where the intestine is normally like this. It telescopes, rolling over itself. That's interception. Fine. Lymph node, again, when I have the classical finding, here I don't want you to write effaced because everyone knows about lymph node of Burkitt's. It's a classical starry sky appearance. If you want to expand starry sky, stars, the white areas are the macrophages, sky, the blue areas are the tumor cells, right? So the star is nothing but the macrophage or the tingible body macrophage. The sky here is the the blue tumor cells, fine? That's a classical starry sky appearance, fine? Markers, Burkitt's is B cell. So obviously they are 1920 positive by default. And the most important for me is CMYC positivity is very, very important. Okay, I'll tell Ankit. Fine. The next one here for me is CD10, BCL6 if required, because they are germinal center markers. Since they come from germinal center, it will be involved as well. Fine. See, the macrophage name is tingible. Okay, we call them as tingible body macrophages. What happens here is, since Burkitt's lymphoma is very fastly proliferating, the macrophage will keep on eating, but there's no time for them to digest, right? So if you look at the Burkitt's macrophage, I'm not sure if it's visible here. Can you see, these are the macrophage. Can you see tiny blue dots here? These are nothing but the apoptotic cells which have been eaten, not exactly cleared. So it's not always clear or foamy here. I'll have tiny blue dots inside them, right? That's why I call them tingible body macrophages. Tiny dots there inside the macrophage. Fine. Okay, Nikhil? Okay. Prognosis complication. Burkitt's is a very, very aggressive disease. Fine. One of the complications for me is bone marrow involvement. It can involve the bone marrow. It can go into the periphery. It can cause Burkitt's blast. Okay. We read about Burkitt's blast. Write a word about them. The L3 blast, the sky blue cytoplasm with clear vacuoles. That's one of the problems. Second problem of Burkitt's lymphoma is very highly proliferating. So they might end up in having tumor lysis syndrome. Tumor lysis syndrome can be post-treatment or sometimes even without treatment also. Mostly it's triggered post-treatment only. If you want to elaborate on tumor lysis syndrome, do it for an essay. Short note, don't do it. It's not required. Tumor lysis syndrome, but if you feel you have more time, don't know what to do, right? All the cells will die. So hyperkalemia, potassium goes outside, right? And also your acid-base buffer goes outside. So you'll have acid-base imbalances, fine. Your phosphate goes outside, which is also a buffer. Phosphate binds to calcium, so calcium will be lower. Nucleus will be destroyed. Hyperuricemia, uric acid will be more. Classical symptom of tumor lysis syndrome. If required, write it. Okay. There's always a misconception that if I write more, I get more marks. If you write correctly, you get more marks. If you're not sure about the tumor lysis syndrome features, just write tumor lysis syndrome. Because of very fast proliferation, group of symptoms will be seen. That's enough, right? That's about Burkitt's. Let's come to Hodgkin's. Hodgkin's does not have a very clear pathogenesis. I have two etiological factors. I'll talk about both of them. Hodgkin also, it's said to be arising from germinal center. It's said to be arising from a crippled germinal center B cell. Okay, cripple means it's going to die. So this about to die germinal center B cell will either be hit by my Epstein-Barr virus, which gives nuclear factor K beta, which is going to revive the dead cell or revive the dying cell. It's dying, so I'm going to give some nutrition. Or I have a mutation called as REL, not RET, REL proto-oncogene. Okay, so that also is going to cause the revival of a cell which is about to die. Post chemotherapy, not surgery. We don't do surgery for lymphomas, right? It's chemotherapy, fine. So once we revive, it will have an altered functionality or altered expression. So it kind of behaves like a macrophage, and the tumor cells start secreting interleukins. So they start secreting interleukins. Good evening, comrade. So what I'll have is, you will have the tumor cells. Along with the tumor cells, you will have surrounding inflammatory cells. The surrounding inflammatory cells is more diagnostic of Hodgkin's lymphoma in addition to the tumor cell. Only RSL is never diagnostic. RSL with surrounding inflammation is diagnostic, fine. So a revived B cell alters its functionality, behaves like an activated macrophage, secretes your interleukins, becomes a Hodgkin's lymphoma, right? This is the simplest pathogenesis of Hodgkin's lymphoma, fine. History, same. Hodgkin's can be seen in adolescents, little bit in young adults than in elderly. It's not a tumor of later age, most likely young adults. When I say young adults, in the age of 30s, 40s, I can have it. But follicular, your mantle, CLL might be seen above 40, 50 years of age, fine? Okay. Again, generalized lymphadenopathy will be the classical finding. Okay. But there's a very classical fever in Hodgkin's. Can anyone tell me that? Please do mention that fever. We have a very specific type of fever called Pelebstein fever, right? You must have read that in your medicine postings. You must have not read that in pathology. But yes, Pelebstein fever is a very intermittent fever, which is classical of Hodgkin's lymphoma. Clinical features are not something which you read from Robbins. You must have gone for 1 year of clinical postings. Take from that. Knowledge doesn't mean that it should come from only one textbook, right? Whatever you know. Pelebstein fever is an intermittent fever characteristic of Hodgkin's lymphoma. The reason of intermittent, interleukins come. Interleukins are secreted in bunches. That time you'll have fever, slowly will reduce. Again you'll have a spike, again it reduces, fine? Okay. Lymph nodes. So lymph node here, obviously the effaced architecture will be there. That's by default characteristic, fine? In addition to the effaced architecture, the diagnostic point in a lymph node is, like I said, RSL plus background inflammation. Background inflammation is more diagnostic than the RSL. Okay. So based on the RSL and background inflammation, we classify them into two major groups. One is classical Hodgkin's lymphoma. The other one is NLPHL. Okay. The classification is ideally based on the origin, but microscopy also will have very different microscopy. Classical and NLPHL. If you're having a question on Hodgkin's, there's no way without writing all the 5 subtypes, you should finish the question. Classical Hodgkin's will have nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted, and I have NLPHL, right? You need not write everything. If you have time, do write everything, but at least few salient features, right? Nodular sclerosis is the most common subtype. Generally, they are discovered in stage 1 or stage 2. That's why they have a little bit of a better prognosis. Here, you will have every classical Hodgkin's lymphoma will have the classical RSL. You can write classical RSL plus one finding called as a lacunar variant of RSL. Okay. Diagrams draw whenever required. Fine. Classical RSL, the outside, the classical binucleate cell, you have to write it. Fine. It's nodular lymphocyte predominant, right, Aniket? That's the background inflammation. Right? That's a background inflammation here. Background inflammation reason is because the lymphoma cells are having a different functionality of secreting interleukins. When they secrete interleukins, it's going to attract more WBCs. That's why background inflammation is there, fine? Yes, if you want, write developed nations, more seen in developed countries. And one thing, don't forget, since it's in developed country, they are EBV negative. This must. See, these are must know. Most common, EBV negative, classical RSL, and lacunar variant. The name can give me one more finding, nodules of sclerosis or fibrotic band. That also, if you can want to write it, right? Mixed cellularity, it's common in developing countries. I don't like to call India a developing country, right? They're developed, right? At least with respect to Hodgkin's, right? I have lots of, it's more common in developing countries, mostly discovered in later stage 3 or stage 4. So prognosis a little bit drops, fine. Mixed cellularity will have again classical RSL, which is a classical binucleate, plus I have mononucleate RSL, right? Mononuclear cells are classically seen in case of mixed cellularity. Mixed cellularity. Background I'll have T lymphocytes, eosinophils, macrophages, plasma cells, everything. I'll have mixed cells in the background along with the different types of RSL. See, I always have this problem of Hodgkin's, which is more common. As per books, I have to lean towards mixed cellularity because books are not updated. But if I go to the Indian scenarios records, it's always nodular sclerosis. It's moved a little bit towards that area, fine. And please don't forget, developing nations, so it has to be EBV positive. The reason for me writing developing nations is infection associated. That's why I'm saying it's developing nations. That's all fine. Then lymphocyte rich. Lymphocyte rich, again, I'll have more of mononuclear RS cells and also your classical RS cells, right? Lymphocyte rich, I'll have good amount of T lymphocytes alone in background. I won't have your eosinophils here. They're lymphocyte rich. As the name says, lymphocytes in the background, lots of lymphocytes in the background. This also is EBV positive, fine. So also is an EBV positive lesion, okay? Lymphocyte depleted. Here I can have mononuclear, I can have classical RS cell, but one classical finding here is your mummified RSL. Mummified, other name is your reticular variant, or just write mummified variant of an RSL, a smudged appearance. EBV positive, and also one more thing positive, HIV positive. That makes is the worst prognosis. The prognosis is very, very bad of the deadly infection, and because of that, the entire tumor also becomes very pleomorphic and becomes a little bit more aggressive, right? That's classical for a lymphocyte depleted variant of Hodgkin's lymphoma. Last but not least, NLPHL. NLPHL is totally different. Okay, it's seen mostly in young individuals, mostly seen in single cervical lymph node involvement. Okay, as the name says, it's nodular, right? The origin is also very, very classical. Origins from your centrocyte. Centrocyte, classical centrocyte origin. Mummified, Samantha, is destroyed. The entire cell looks completely destroyed, a smudged nuclei, fine. What's a microscopy? It's nodular, and your I'll have nodular appearance, and obviously the classical RS cell here is the popcorn variant of an RS cell. Okay, popcorn variant is nothing but a cleaved or an irregular nuclear membrane makes it appear like a popcorn, right? That's why it's a popcorn variant of RS cell. It's a pure B cell lymphoma, right? So here the background of NLPHL will be B cells. B lymphocytes in background, similar to any other B cell lymphoma. I have B lymphocytes in background, and they are one of the best prognosis. Okay, everything regarding NLPHL is unique. If you want, write all of them. If you can write a table and draw, write it. It will be much more efficient, right? So there are few things which I want you to write. Never forget what RSL LC. EBV will be helpful. NLPHL is also EBV negative, right? So EBV status will be helpful. Prognosis will be helpful. This also is EBV negative. Fine. Here is more of mutation. What is in the background will be helpful. The type of RSL is also very, very helpful. If you want add prognosis, prognosis gives you extra marks. That's all, fine. So 5 different types of Hodgkin's. Divide them into classical and NLPHL, right? Then obviously markers. Markers again is based on classical and NLPHL. Tell me the markers. What's the marker for classical Hodgkin's lymphoma? Classical Hodgkin's. CD15, CD30. That's a marker for classical Hodgkin's, and here CD15 and CD30 are negative, and they are positive for CD20, CD45. I must have told you one more marker in class. Apart from CD15 and CD30, the other marker is PAX5, right? You've forgotten PAX5. PAX5 in case of classical Hodgkin's will be weakly positive. It has to be weak. And here PAX5 will be strongly positive because it's a B cell marker. NLPHL is a classical B cell lymphoma, so it will be strongly positive, and a classical Hodgkin's lymphoma it will be weakly positive. Fine, that's about Hodgkin's. Hodgkin's know about the pathogenesis, the symptoms. The most important Hodgkin's is this. The different types of Hodgkin's lymphoma, which is very, very important for you to memorize and revise. Fine. Okay. Okay. Last but not least, CML. You guys are going to tell me the template. I am going to fill whatever you guys say. Hodgkin's lymphoma is a B cell neoplasm. All the non-Hodgkin's lymphoma what you read, as well as Hodgkin's lymphoma, most of them are B cell neoplasm. We have few T cell called as mycosis fungoides, Sécharia syndrome, or your ALCL. Those are T cell neoplasms. Okay. Origin. It comes from the myeloid stem cell. Okay. So all the myeloproliferative disorder comes from the myeloid stem cell or the B cell myeloid stem cell. Okay. In myeloid stem cell, perfect. You have a translocation 922, the Philadelphia translocation and the Philadelphia chromosome. which will have a fusion product of BCR-ABL. This BCR-ABL fusion product is going to increase the tyrosine kinase activity. Whenever the tyrosine kinase activity is more, it's a kinase. By default, there'll be more faster cell cycle. If you can write 210 kilodalton, otherwise just write the fusion product, fine. I can have more and more and more proliferation. So more and more and more proliferation does not just happen in the bone marrow. Obviously, it will happen in the bone marrow. It will also happen in your spleen. That's the reason the patient has a very big, massive splenomegaly. That's a classical symptom. Every hematolymphoid organ, liver also, it will happen. They'll start producing WBCs, so it becomes a very high WBC count. Fine. Okay. History: elderly or young? Elderly. What will be the classical history of CML? Elderly patient presenting with a very vague abdomen pain or heaviness due to a massively enlarged spleen. That will be the classical symptom, fine, in elderly, and a very vague abdomen heaviness or a pain. Most of the symptom will be that, because splenomegaly is an examination finding, right? Symptom will be a vague abdominal pain or a vague left side pain, something of that sort, right? On examination, by default, you'll have a massively enlarged spleen. Okay. Massive splenomegaly is classical, right? So whatever points you told is the one I am expecting in your answer sheet. If there's BCR-ABL in a 5 mark, 1 mark is sorted. Tyrosine kinase, 1 more mark is sorted, because tyrosine kinase is a mutation. Classical splenomegaly, elderly patient are the point. Peripheral smear, leukocytosis or not? Before peripheral smear, I need the CBC finding as well, right? It's a leukemia. I definitely will have elevated TLC count. That's by default there. Okay, will be there. And the most important finding, like Lion said, basophil. Basophilia is diagnostic of CML. I will always think of CML when I see basophilia. Then comes peripheral smear. In peripheral smear, it's a chronic leukemia. So I will not have only immature cell, both mature and immature. If you want, write the names of garden party appearance or your college girl appearance. I don't vouch for that, but if you want, write that, fine. Peripheral smear, the classical term which I'm looking for is left shift. Neutrophilic left shift or shift to left. That's what is required. Where you'll have a little bit of blast will be there, myelocytes, metamyelocytes, band forms, and also neutrophils. Okay, I'll have all of them in case of your CML, right? All the cells will be there. That's a classical left shift. Left shift means all the immature cells comes to periphery. You don't want a bone marrow in case of a CML. Peripheral smear is more than enough. Once I write this, the next thing is I have to classify CML. Either it's a chronic phase, accelerated phase, or blast crisis. As per the new WHO, these two are merged. If you want, write below, but at least for undergraduate, I would expect you to know all the 3 phases. Maybe below write that as per the WHO 2023. There are only 2 phases of CML, where the chronic phase and accelerated phase has become a single phase, and I have blast crisis. That's all I have. I don't have 3 phases, only 2 phases of CML now. Fine. Okay. If blast is less than 10% and basophil less than 20%, rest everything classical finding of CML, I call it chronic phase. 10 to 19% blast, basophils more than or equal to 20%, leukocytosis, either platelets being more or platelets being less, both are diagnostic, and there is no response to treatment. When I say treatment, I am talking about imatinib. I gave the patient imatinib, the spleen did not reduce in size. I gave the patient imatinib, WBC count is not reducing. Again, I think of an accelerated phase, right? As I said, now both of them are together, fine. Blast crisis in the bracket, right, is nothing but an acute leukemia. Chronic leukemia has become an acute leukemia, which means blast is more than equal to, what's the percentage? For every acute leukemia is 20%, either in PS or bone marrow. And extramedullary blast. When you have blast in the skin, blast in the lymph node, blast in the gums, blast retroorbital space, right? That's my extramedullary blast. I call it obviously a blast crisis, fine. So this is must for CML. So once I think of a CML, then obviously I categorize. Once I categorize, then I have to confirm CML. CML is not confirmed on flow cytometry. CML is confirmed on genetics, right? You need genetic testing. I don't want flow cytometry here. You have lots of time and you get dual. This one, Samantha. Neutrophilic left shift, leukocytosis, increase in basophil is a classical finding or peripheral smear finding of an CML, right? Okay. Genetic testing, I can do FISH or a qPCR, a real-time PCR. If it's not available, I go for a karyotyping. Definitely FISH or PCR is superior than karyotyping. There's no doubt in that. Karyotyping is a bit cheaper and not that accurate compared to FISH or a PCR, fine. If you want, you have to write a word about the treatment, imatinib. See, CML treatment, I'm sure you know that because you must have read in your pharmacology also. Imatinib, a tyrosine kinase inhibitor. Can you guys tell me any other treatments? I'll tell Samantha. You must have heard about ponatinib, dasatinib. Those are second generation tyrosine kinase inhibitor. You can add that. Imatinib is the first generation tyrosine kinase inhibitor. Fine. Okay. If you want to draw an image for a CML, see, I want representative diagrams. That's all, right? So I draw a couple of neutrophils. Neutrophils will be lobed. Okay, you'll have lobes here. Then I draw a few band forms. Band forms will not have a lobe, right? It will not be exactly lobed, but it's more kind of intended, right? A metamyelocyte will have a kidney-shaped nuclei. Obviously, everything will have granules. A myelocyte or a blast will have a D-shaped or a big nuclei, right? So, and obviously, you'll have basophils. Okay, just a representative diagram. You can say that all these are mature neutrophils. If you're not able to differentiate an immature cell, just write immature WBCs, the metamyelocyte, myelocyte, and everything, and draw a diagram of basophil. Fine. Okay. If you want, right? But if you tell them in writing also, I'll see all the lineage of maturation. That also should be more than enough for a case of a CML. Fine. Okay. That's about your WBC class. Fine. I have not covered your polycythemia vera, ET, and essential thrombocytosis, though it's there. I have not covered much of MDs also because the CBMA is not much concentrating on that. But I'm sure if they concentrate, you'll be able to write, right? So we read the both two leukemias, almost every lymphoma required. I didn't cover DLBCL because DLBCL is a comparison of everything, right? Next class of mine is, I think, in Friday, maybe, but in between, sometimes I'll try to take the coagulation, fine. Use a different color, Aniket. I think that should be helpful for you because highlighting, I don't know how good your quality of paper is. If highlighting destroys the paper, then there's no fun. Maybe have 2-3 colors and use it, fine. Myeloma. Yeah, I should have covered myeloma, fine. I didn't cover myeloma. I don't have it for now. But to write for myeloma, again, chromosomal disorders, translocation involving 14th chromosome. By default, a plasma cell is going to have more of interleukin 6. That makes them more neoplastic and it keeps on dividing. That's a pathogenesis for myeloma. Symptomatology, elderly, bone pain, anemia, fatigue is a classical symptom. Diagnosis is not on peripheral smear. It's always based on the criteria. Draw the 3 things: bone marrow percentage, the presence of your serum immunoglobulin or the M spike, and your CRAP criteria or the SLIM criteria. I'm sure you know the difference between smoldering, your MGUS, and multiple myeloma, right? Then write for the microscopy of bone marrow, normal plasma cell, binucleate, trinucleate plasma cells, Mott cells, Dutcher body, Russell bodies, and serum electrophoresis, the M spike. I hope you'll be able to write urine or your peripheral smear or your normal blood. I can do serum electrophoresis, and then you can also write a word on Benz-Jones proteinuria if required. Fine. Diagnosis is always based on criteria for myeloma. Microscopy, the only thing I require is the number. Mott cell doesn't make a sense. More than 10% should be enough for us. Fine. Aniket, I think CBME does not have exactly like vegetations, but they do have about infective endocarditis and rheumatic heart disease, so they can talk about that. Fine. It's fine, Aniket. See, if the paper is difficult, automatically treatment will become, the correction will become a bit easier. Right? Samantha, they don't have vasculitis under CBME, but I don't know if they will ask it or not. Okay. I'll try to cover the few things left in this week, somewhere in the afternoon. Hopefully, we'll try some 40 minutes or 45 minute session so that it will not affect your original routine. Fine. Okay, guys. Thank you for your time. See you. Bye bye.